It is tempting to look at an aging patient with aching fingers and assume their cartilage is simply wearing out. Consider a patient presenting with classic joint pain, severe swelling perfectly mirrored on both hands, specifically targeting the small knuckles, the MCP and PIP joints. Then you run their blood work, and the results contradict a simple joint problem. They have a severely low red blood cell count, an alarming spike in platelets, and they complain of crushing fatigue and chest pain. If the immune system is supposedly mounting an isolated attack on the small joints of the hand, it does not explain a life-threatening drop in red blood cells or sudden cardiovascular complications. Mapping these systemic fingerprints is what reveals the full clinical picture, a systemic storm where the joint is merely the point of origin. To see where this systemic crisis begins, we have to look inside the joint capsule, at the synovial lining. Driven by autoantibodies like rheumatoid factor and anti-CCP, the immune system invades this space. The tissue becomes heavily inflamed and proliferates, forming a destructive mass called a pannus that steadily erodes the surrounding cartilage and bone. But the joint capsule cannot contain the ensuing chemical warfare. Highly reactive inflammatory messengers, specifically cytokines like IL-6 and TNF-alpha, breach the local tissue barrier and spill directly into the bloodstream. With these molecules in the blood, the disease gains access to every organ, setting the stage for wide-ranging tissue damage far from the original joint. Swept up in the blood, these IL-6 molecules travel rapidly until they collide with their first major target, the liver. The liver interprets the massive influx of IL-6 as a distress signal. In response, it secretes a hormone called thrombopoietin into the blood. This thrombopoietin travels straight to the bone marrow. It binds to massive precursor cells called megakaryocytes, forcing them into overdrive to rapidly butt off thousands of new platelets. This chain reaction is known as reactive thrombocytosis. The body produces an excessive number of platelets entirely in response to the underlying inflammatory signals. That alarming platelet spike on the patient's chart is a direct, measurable consequence of the circulating cytokines. Meanwhile, back at the liver, IL-6 triggers a second, simultaneous defense mechanism, the release of an iron-regulating protein called hepcidin. Hepcidin functions like a biological padlock. It binds to macrophages and enterocytes, locking their iron stores inside the cell and preventing that iron from entering the bloodstream to make new red blood cells. Looking at this split-screen data comparison, we can see the clinical difference. On the left, simple iron deficiency anemia shows a truly empty tank. But on the right, anemia of chronic disease shows a completely full iron gauge that is locked away. Because the body's total iron stores are actually normal or high, blood tests will show a ferritin level greater than 100 nanograms per milliliter. Understanding how hepcidin physically traps iron allows a clinician to immediately distinguish anemia of chronic disease from a simple iron deficiency, saving the patient from unnecessary iron infusions. Beyond the microscopic shifts in blood chemistry, the inflammatory storm makes destructive landfall in macroscopic tissues. In the cardiovascular system, the inflammation frequently targets the heart's outer lining, causing fibrinous pericarditis, which explains the patient's acute chest pain. On the skin, especially over pressure points like the elbows, the disease leaves behind rigid subcutaneous rheumatoid nodules. Under a microscope, these nodules have a very specific architecture, a dead central core of fibrinoid necrosis surrounded by a wall of palisading epithelioid histiocytes. These physical skin regions and cardiac threats are the tangible wreckage left behind by an unchecked cytokine storm. Tracing the path from a single inflamed finger joint to the liver, the bone marrow, the heart, and the skin reveals a highly interconnected biological network. Treating rheumatoid arthritis requires aggressive systemic immunosuppression to extinguish this whole body fire, rather than relying on localized joint pain relief. For board exams, remember these distinct pathways. First, circulating IL-6 drives the liver to produce thrombopoietin, causing reactive thrombocytosis. Second, IL-6 also stimulates hepcidin release, trapping iron in cells and causing anemia of chronic disease. Third, subcutaneous rheumatoid nodules are defined by a core of fibrinoid necrosis and palisading granulomas. And fourth, always monitor for fibrinous pericarditis as a primary cardiac threat. This mechanical understanding replaces rote memorization with a predictive map of the disease, tracing every laboratory abnormality back to the cytokine storm that created it.